I'm Dr. Suresh Ramalingam, Professor of Hematology and Medical Oncology and Deputy Director of the Winship Cancer Institute of Emory University in Atlanta. I'm a thoracic oncologist, and I focus on the treatment of lung cancer and research on lung cancer. What we have learned so far in randomized clinical trials and even some focused phase 2 clinical trials in driver mutated patients, immune checkpoint inhibitors do not have substantial activity. Why do I say that? Well, if you look at the meta-analysis of clinical trials that compare checkpoint inhibitor to docetaxel in the second-line setting, we saw that outcomes were generally better for immunotherapy over docetaxel in an all-comer population. However, when we specifically look at EGFR mutated patients, chemotherapy did better than immune checkpoint inhibition. When we look at response rates with PD-1 and PD-L1 inhibitors in EGFR mutated patients, it's very low, often in the low single digits. Another reason is a very instructive study that was reported from UCLA, where they selected patients with EGFR mutations and gave them frontline therapy with pembrolizumab if they had positive PD-L1 expression. This was an attempt to see if immunotherapy would be better than targeted therapy for these patients. Now, that trial was closed early after only about 12 patients had been enrolled because there were 0 responses with immunotherapy in EGFR mutated patients, even those with PD-L1 high expression. So for all of these reasons now, we do not use immunotherapy in the frontline setting. The first message is for patient with driver mutation, targeted therapy should be the frontline treatment, even if the PD-L1 expression is 100%. Now, what happens when these patients progress on targeted therapy? Well, there are some targets where there are second line and third line targeted therapy approaches, and we would recommend going down that road. If that option is not available, platinum-based chemotherapy remains as salvage option for these patients. Would I use immunotherapy down the road for these patients? I don't think data supports single agent therapy with PD-1 or PD-L1 inhibitors. There's some interesting observation that combining chemotherapy with bevacizumab and atezolizumab may be associated with efficacy in EGFR mutated patients. However, that has not been prospectively verified in a phase 3 trial. And those sort of trials are currently ongoing. So at this point in my practice, for patients with driver mutation, targeted therapy comes first, chemotherapy comes next, and clinical trials come third. I rarely ever use immunotherapy as monotherapy in this situation.